Good morning, good afternoon, good evening, everyone, and welcome to this Zero Dose webinar series with the collaboration of TechTet 21 on how immunization supply chain contribute to identifying, targeting, and reaching zero dose communities. This second session today will focus on immunization supply chain interventions. We're going to talk about lessons and best practices for reaching underserved zero dose communities. You can listen to this presentation in French and Spanish, en français et en espagnol, traduction disponible. To do so, please select the globe at the bottom of the Zoom window and choose the desired language, français or espagnol. If you struggle to find it, just let me know in the chat area and I can help you. You can already introduce yourselves in the chat area, so don't hesitate to tell us where you're from and who you are. That's always a delight to know who we are talking to. And also, if you have any question during the presentation, please use the Q&A box that is available at the bottom of the Zoom window. If it's probably not your first webinar session, so I guess you know where to find it. And ask your questions at any point. Our colleagues are going to answer them either in written or orally after the session. Finally, just to let you know that this session is recorded and we'll share with you the links to the videos in French, Spanish, and English, as well as the slides. I hope you enjoy this session, and I'll give the floor to Olamide, who will introduce the session. Thank you.
Thanks very much, Alex. Good morning, good afternoon, good evening, everyone, well, wherever you're joining us. We're excited that you have joined us for the second in this series of the immunization supply chain contribution to zero dose, reaching, identifying, targeting, and reaching zero dose communities. As you know, we started last week with the first webinar around supply chain guidance and strategies. Today, we'll be talking about supply chain interventions, zeroing in on voices from three countries that we'll introduce shortly. And we have a star-studded panel that would share their experiences. Hopefully you glean some good practices and best practices from them on how supply chains can contribute to reaching zero-dose communities. Bottom line is the fact that we're hoping that in all your work in the region, countries wherever you work, that you continue to see supply chains as not just an operation, but a critical enabler to program outcomes, including reaching zero-dose communities, but also under-immunized children. So the third in the series will be next Thursday on the 23rd, and I will talk about integrated supply chain approaches. That is, how does the supply chain intersect with other program areas to deliver products to the last mile? So that would also hold at the same time. So please join us. Would like to see as much of us joining that. Without further ado, we have three country presentations today on how supply chain interventions contribute to underserved zero-dose communities. Our first speakers will be from Democratic Republic of Congo. So I have two colleagues joining there. So we have Dr. Dio, who is health specialist with UNICEF DRC, and then we have Patu joining from VillageReach, the deputy country director for VillageReach. They're both medical doctors and have extensive years of experience supporting immunization programs, but also not only immunization programs, but broader health systems strengthening. So without further ado, we have 20 minutes. We'll run through presentations for each country for 20 minutes each, and hopefully we'll take questions after. We're hoping that you have a lot of questions where you want them to expand more, but please also use the chat functions like Alex has said to drop your questions, and we may be answering them as we go. But at the end of the presentations, you would have an opportunity to also speak up. So we'll be glad if you want to speak up. So without further ado, I'll pass on to Dr. Dio from DR Congo for his presentation.
Good morning, everyone. As Olamide said, I'm Deogracias Manirakiza. I'm a health specialist working on immunization program here in DRC with UNICEF. I will proceed on the presentation with my colleague, Patu, who is working with VillageReach, our privileged partner here in DRC, particularly on the scale up and the support to the cold chain and the distribution of vaccine at the last mile. Can go to the next slide. This is the current flow of vaccine distribution in DRC. As you can see, all vaccine coming from outside the country arrive first at Kinshasa airport. They are storing at the central hub called the Kinkole hub, and then their distribution to different provinces and the health zone from Kinshasa. The main means of distribution are flight. There are not enough infrastructures by road to distribute by road. Slide. Next slide. Because of the distribution by flight has a high cost, the country has reflected about the reconfiguration of the supply chain here in DRC. And what has been decided is to land vaccine when they come outside the country to the 4 points. Flights coming outside the country, part of the delivery are made at Kinshasa. Other deliveries should be done at Kisangani and Goma and Lubumbashi, the red point. At this point, the country has international airport and there are regular flights to this area so that the distribution could be done from this point. This is the new configuration. Slide. With this new configuration, we will have 4 hubs, 4 entry points, and from these 4 entry points, the distribution of vaccine and injection materials and also other medical inputs should be distribution according to this flow. Slide. What about the distribution from the province and the antenna level to the peripheral distribution to the last mile? As you can see on this graph, when the vaccine arrives at the central level, the main mode of distribution is the pooling mode. At different level from the province to the health facilities, the main mode of distribution is the collection mode. Slide. What we want to do with the new configuration is to implement the delivery mode so that people designated at a provincial level should ensure distribution to the health zone level, health zone distributed to the health facilities, and the health facility distributed to the vaccination sites to ensure that vaccines are available and are always available at the last mile. What UNICEF is doing now to support that supply chain are optimized, and we have all vaccine at the last mile. First, UNICEF has supported in the last 2 years the implementation of the vaccine independence initiative. This has has reduced considerably the out of stock of traditional vaccine at the country level. This will also, we are analyzing that how this initiative could be extended to vaccines used in supplementary immunization activities, as well as COVID-19 vaccine and injection materials. On the cold chain and other storage warehouse, UNICEF is supporting the construction of 3 hubs. There is the central hub, the Kinkole at Kinshasa, who is already operational. We have the King Sangani in the north, who is already operational, and now UNICEF is constructing in the south, the Lubumbashi provinces, the Lubumbashi town, to support the distribution in the southeast provinces. Also, UNICEF has signed a long-term agreement for the distribution within the provinces via field offices to ensure that distribution are arrived at the last mile. Slide. The other support that UNICEF is implementing now is the implementation of the financing we got from World Bank, Gavi, and in COVAX initiatives. From the 3 funds, UNICEF has purchased almost over 3,000 of materials. Can you back on the materials, please? Here, yeah. We have already purchased 3,000 refrigerators, 134 freezers, and 14 solar cold room, 50 power generator, and a lot of remote temperature monitoring devices. For the moment, all these material are on the stage of reception here in the country. And the main work of this year will be their installation on a different site, as mentioned here on the next slides. Next slide, please. This map shows different sites of the project's implementation. We have in the blue colors the sites which benefit from refrigerators and the other materials supported by the World Bank. The yellow fever are supported by Japanese fund. The red points are supported by COVAX, and the yellow points are supported by Gavi. Slide. UNICEF also is supporting the capacity building for health workers. There are many workshops on the preventive maintenance for refrigerators and cold room. Slide. Okay. I think I'm at the end of my presentation. I want to let my colleague Patu to present about the use of drone to distribute vaccine till the last mile. a project that we are implementing with VillageReach in the remote provinces.
Thank you. Dr. Patu, over to you, please. I think you have about 10 minutes also for your presentation.
Okay, thank you very much, Olamide, and thank you, Dr. Dale, for the presentation. I really want to quickly thank the organizer of this webinar series for the opportunity given to us to introduce the technical assistance that VillageReach is providing to the Ministry of Health, particularly to the EPI program here. And this work is done with the support or the strong support from UNICEF and Gavi, to which we're extending our gratitude. And this presentation, as the title aligns, we will try to see how two of our solutions, drones and the next generation of supply chain, are contributing to reaching zero dose and under vaccinated communities. Next slide. I will not dwell on this slide, but I just wanted to highlight here the mission of VillageReach, which is to transform healthcare delivery to reach everyone. Next. And here just showing that we have our footprint in 19 out of the 26 provinces of the DRC through our different project and solutions that we implement in the country. Next, please. So let's now get to the nuts and bolts of the presentation and see how the drones and how the next generation supply chains are contributing to reaching zero dose communities. Next. Regarding the Drone for Health program or solution, it is important to note that the project started in 2019 and the drones are being used since then in the transport of vaccines. These include vaccine for routine immunizations or in case of a campaign. The drones are also helping with the transports of lab samples, the transports of personal protective equipment, and interestingly also with the transport of medical reports, because those are bi-directional drones. So when they go to provide vaccines, they don't come back empty. They come back whether with lab samples or medical reports from the health facilities where they're serving. Next slide. So in this slide, we want to illustrate the current network of the drones in the province of Equateur. It is important to note here that we are currently doing the reconfiguration of the network, but so far it is what we're using. So the main distribution center is at Wenjisekli. Wenjisekli is at 20 kilometers from the district office of Mbandaka. And from Wenjisekli, vaccines and other health products are transported to secondary distribution centers at Bikoro and Lulanga Mubako. And this network actually covers 40 hard-to-reach health facilities. And this is really here the added value of using drones for transporting products. It's their ability to reach hard-to-reach areas of health facilities. And they don't only reach, but they reach those areas rapidly. So there is the speed and the capacity to reach hard-to-reach areas. For example, if you take from the distance from Wenjisekli to Ingende, it's about 185 kilometers if you travel by roads, or 115 kilometers if you travel by the river. But it takes only 50 minutes for the drones to cover this distance. And as you can imagine, this is not possible if you use the traditional way of traveling. Next slide. It is also important to highlight that drones are used in both the routine delivery of vaccines, but also on demand. And this is particularly important for health facilities which do not have a functional cold chain or refrigerator. Next. And here I would like to particularly highlight the role that the Drone Working Committee Group is playing at the provincial level in terms of helping with identification of mixed communities. This group is under the leadership of the governor himself, and they meet every 3 months. And it includes the provincial minister of health, the EPI antenna head medical doctor, and many other important stakeholders from the community. And during those meetings, they do the triangulation of data, the consumption data, and the service delivery data. And this gives an idea about which communities were missed during vaccinations, and at the end, recommendations are provided at the lower levels of the health systems to address the issue. And they're doing really a good job about that. Next slide. And we have already underlined that drones help with on-demand delivery of vaccines for reaching, for organizing vaccination session in order to reach isolated communities. Will likely include 0 dose and under-vaccinated children. And this is just an example here of the health center of Ekele and Bondo, which were able to maintain their vaccination session despite the fact that they did not have any operational or functional refrigerator. And we're also able to support the yellow fever campaigns in the health area of Manga in those isolated islands of the health area. So this is just to illustrate the impact that the drones are having in those areas. Next slide. Another advantage of using drone is that they offer more time to healthcare providers to organize vaccination session. And I'm quoting one healthcare provider in one of the health facilities that is supplied by drones. He said, I used to go at Ingende by bicycle at 75 kilometers from here to pick up vaccines and come back very exhausted. This caused uncertainty for planning for our fixed pulse and outreach vaccination session. Now that we are supplied by drones, we can respect the planning of our vaccination sessions, and there are no more stockouts. So this quote just translates the impact of drones on the vaccination services in those areas. Next slide. And another solution that we implement that I would just quickly elaborate here is the next generation supply chain. This approach includes a direct distribution of vaccines to the health facility, rather than the traditional approach where the healthcare providers from the health facilities have to go to collect vaccines and other health products from a higher level. And you've seen one of the slides that Dr. Dare has presented. The distribution system in DRC is largely dominated by a pool system where providers from the lower levels are going to collect medical product from the higher levels. But with an NGCA, it's the other way around. We're pushing for direct distribution. And this direct distribution is coupled with formative supervision. So in the efforts to identify and reach zero-dose communities, we have introduced during the formative supervision, the triangulation of the vaccination register data and also the service delivery data. This data triangulation is helping to identify which children were missed during vaccination. And we have also developed an identification sheet where 0-dose and under-vaccinated children are documented, and another tool that helped to assess the 0-dose and under-immunized children who were able to be vaccinated following the recovery vaccination session. So those tools were co-created, and this is very important to note here, they were co-created with the herd nurse and also the community health workers who are helping with identifying 0-dose kids in the community. Next slide. This is just a highlight of some of the results from the drones. As you can see, from December 2020 to December 2022, we have realized a total of 4,408 flights, translating to approximately 200,000 kilometers. And this is like traveling around the Earth 5 times. So it's really a substantial achievement here. And you can see that we were able to reach more than 62,000 children with vaccinations. Next slide. And here you can see the 2 pictures illustrating the for the identification sheet and their what we call plan de récupération, so the recovery plan to vaccinate 0-dose and under-vaccinated children. And those were filled out by head nurse and also the community health workers who are working on the fields. Next slide. And in this table, we can see the number of 0-dose kids, children that we were able to identify in 3 provinces where we are implementing the next generation supply chain, and also how many of them we were able to vaccinate. So this is really, in a nutshell, the work that we're doing in the field, and to try to help with this huge problem of 0-dose and under immunized kids in DRC. Thank you very much.
Thanks very much, Dr. Patu. I know we had said that we'll take questions at the end, and thanks, Dr. Dio, for responding to some of the questions. I just wanted to give you opportunity, maybe in like 2-3 minutes before we move on to the Nigeria presentation, if you want to respond to some of the questions live. There's one from Karan, which asks if you've mapped the cold chain installations and 0-dose communities to make sure that, or to see if the cold chain equipment installations are contributing to 0-dose. Dr. Dio and Dr. Patu, if you want to respond.
Okay, thank you, Olamide. For the first question about what kind of temperature monitoring devices used here in DRC. As I responded in the chat, the main devices we use to monitor temperature in the fridge tag. But there are some new initiative that which is being implemented to test the parcel. We purchase now around 12,000 parcel materials to be installed and evaluate after some times, so that the country could decide, could make a choice on which kind of devices he wanted to implement in DRC. The second question was about, let's see the charts.
Well, as you're responding,
how we monitor the availability of vaccine at the last mile. For the moment, the tool which is being used in the Mashako Plan monitoring system, it is a web-based monitoring system. Informations are collected by supervisors at the health facility, and those, normally each year health zones and the provincial management team are deployed to supervise antenna health zone and health facilities, the availability, among others, the availability of the vaccine. But what we realize is that even at the central level, the availability of the vaccine is a full availability along the year at the central level. At the peripheral level, particularly on the vaccination sites, we still have a global performance at 70%. So there is a need for improvement on our supply chain, particularly on delivery at the last time. The country is a very large country with very weak infrastructures, but we are analyzing what alternative solution we can implement to make so that vaccine are always available to the last time.
Thanks very much. Maybe to Dr. Patu quickly in like 2 minutes. There's been a few questions on the sustainability of the drone model and one specific question about the cost. So could you comment about the sustainability of approach you have for the drones project to make sure that it is cost effective? Over to you in 2 minutes.
Thank you very much, and I appreciate the question. We conducted actually the School of Public Health of Kinshasa conducted an evaluation of the drone program in Equateur to assess the performance of the solution, and also to assess the cost effectiveness of it. And currently, we've already had results regarding the performance, and we were able to show that where drones are being used, there has been increased availability of vaccines at the health facility level. And analyses are still ongoing in terms of the cost effectiveness of the drone solution, and we'll be very happy to share the results whenever it will be available. But I would like here to highlight the fact that when it comes to working to reach zero-dose communities, the question that we're asking here is, how much should it cost for us, working in the health system to reach one child who's living in a very limited or very isolated area? So we need to really look at these questions with a lot of care and attention, so that the cost shouldn't be a barrier for us to reach out to those children living in isolated communities.
Absolutely, I think that's a very good place to end that intervention. The value add of innovative supply chain activities would go beyond cost. Would include as much as possible how much contributions we are making to program outcomes, including vaccine availability, reach, integrated supply, reduction in zero-dose communities. We can pick up on that later. We'll move straight to the presentation to Nigeria. We have two presenters, Pharmacist Awatente, the Director for Logistics and Health Commodities with the National Primary Healthcare Development Agency in Nigeria, and Dr. Ahmad Isa Muhammad is the health specialist with UNICEF Country Office Nigeria. So I think I'll pass it on to Pharmacist Awa and Dr. Ahmad for the presentation.
Okay.
20 minutes.
All right. Good afternoon, everyone, and we're delighted to be here. Presenting for Nigeria will be Dr. Ahmad Isa, who is the health specialist from UNICEF. So he will be presenting on our behalf. Dr. Ahmad, over to you.
Okay, thank you very much, Director of Logistics and Health Commodities in the Nigerian National Primary Healthcare Development Agency. The outline of our presentation, of course, include the Nigerian country immunization supply chain profile and indicators, and also the zero-dose targeted areas and how system design analysis that was conducted in the country favors the coverage and equity reduction, the stock management, and also the cold chain expansion and what cold chain equipment saturation in view of the burden of the zero-dose. So by way of introduction, Nigeria has a five-tier immunization supply chain levels. You could see that as at now, we have a single point of entry of vaccines, that is in Abuja, that supplies to the 6 zonal stores and also the 37 states. We currently have about 774 LGS that are being served by the state stores. and that we have about estimated 10,000 equipped health facilities in the country that served the unequipped health facilities using various modes of vaccines distribution. Next. So this is just to provide the performance profile of the country in terms of service delivery, that is the coverage of Penta 3. You could see Nigeria has achieved tremendously in terms of Penta 3, rising from 33% in 2026 to 57% during the 2021 multiple indicator cluster surveys and national immunization cluster surveys. For the effective vaccine management, Nigeria continued to register a serious progress, starting with 52% in 2010, and in 2021, here we are achieving up to 78%. Of course, this achievement is not similar at all the supply chain levels. The national level, specifically the national strategic coastal, have achieved more than the targeted threshold of 80%, but of course the health facility levels is lower than the expected. So overall, for the immunization supply chain system indicators, the country has also achieved quite much, especially in terms of the quality, which in 2021 we have achieved up to 98%. And of course, the efficiency has improved from 74% to 92%. So Nigeria, as part of the zero dose strategy, has identified 100 LGAs in 18 states targeted for a reduction of zero dose. This identification of the 100 LGAs was based on the composite criteria looking at the burden of unimmunized with Penta 1, unimmunized with Penta 3, and also unimmunized with measles containing vaccine first dose. We'll also look at the circulating vaccine-derived polio virus outbreak and also the breakthrough transmission states, and also the measles outbreak in other states. Of course, the LQAS performance was also put into consideration. Next. So system design and last mile vaccine delivery is one of the strategies that we look at in addressing the zero dose issue in the country. There is inherent challenges around the inadequate storage space at national level, and also inefficient vaccine distribution system at the last mile. So in response to these inherent challenges, the Nigeria has since outsourced the distribution of vaccines from the national level up to the state level. And there are some form of vaccine delivery using the outsourced system and also in-sourced models from some states to ensure last mile delivery. And then Nigeria has also conducted system design analysis in 10 states, trying to identify the best way of vaccine delivery and also to improve the efficiency and ensure availability of vaccines. So as part of the plans, we are implementing a DRIVE initiative as expansion of the existing vaccine delivery models that have begun in other states to ensure that vaccines are available at the last mile using mixed models. We are also ensuring vaccine availability in security compromised areas such as in Borno, Yobe, Kaduna, and some other part of Northwest. And this involves the collaboration with the military, use of RTEC devices, and also Indigo that has commenced in Borno. States like Kaduna has since commenced the use of drones to ensure delivery of health commodities, including vaccines. Next. So briefly to touch on the system design analysis that was conducted in 10 states to improve the sufficiency of vaccines at service points and also increase efficiency of the system. We have tried to look at some of the distribution nodes, how we can improve in terms of the management of the distribution nodes, addition of distribution nodes, or closing some of the non-performing distribution nodes. In some states, like in Kebbi, some of the distribution nodes will be skipped to ensure a direct delivery of the vaccines. So we also look at the efficiency of the system, looking at various scenarios, and also looking at the time spent, the logistic cost per delivery, and also the storage capacity utilization. The result of the system design analysis is available, and some level of implementation of the recommendation of the system design analysis has begun and already producing some level of results. So learning from the experience of the last mile delivery in 4 states, we have since commenced the discussion around the implementation of Drive initiative. You could see in some states like Bauchi, where we had up to about 73% of stock out. After the implementation of direct vaccine delivery, we are registering less than 1% stock out. And also Kano, where about 45% of stock out is being registered prior to the introduction of direct vaccine delivery, they moved to only 1% stock out episode. And same thing with Sokoto, with the 61% that have moved to about 8%, and also Zamfara states, where they were recording about 49% and have moved to less than 1% stock out. Next. So Borno State has started using Indigo system to deploy our vaccines to some hard-to-reach areas, and to ensure that the areas that are affected with the security situations are getting the adequate vaccines that is required. So this commenced in 2019, and that by June 2023, it is expected that the project will be expanded based on the outcome. Of course, we have monitored some of the progress that have been registered using the Indigo. You could see that the overall average total number of children that have been vaccinated in those areas have improved by over 117%, which is really contributing to addressing the zero dose in those settlements. Next. So as I highlighted, Kaduna State has since commenced the use of drone to deliver vaccines. As at December as of January 2023, up to about 370,000 doses of vaccines have been delivered to poor terrain and security compromised areas. They were able to conduct about 13,000 deliveries, of which about 224 RI vaccines were delivered, and also over 154 doses of COVID-19 vaccines. This initiative started in August 2020, and that all LGAs are being planned, but currently the selected settlements in 12 LGAs are being served from a single distribution points, where the rest of the 2 distribution centers are being constructed. So the delivery locations have been selected based on the terrain and security challenges, as these are very critical barriers to the coverage and equity of health services, including immunization. Next. So stock management is one of the areas that we look at to ensure visibility of vaccines, especially in the zero dose settlements, so that interventions can be mounted in those areas to ensure vaccine sufficiency. Next. So Nigeria has deployed Open LMIS with LGA a level of utilization of up to 70%. This is really a tremendous progress to the country in terms of addressing zero dose. Next. So the Tribe 360 deployment is in progress. following the recruitment of the BMS in the country, the stock reporting has markedly increased, and that the monthly stock reporting for Tribe 360 has, for the last 11 months, has commenced, and the National Logistic Working Group our members have been oriented on the usability and also the value that the Tribe 360 is going to add to our stock management system. We have since commenced the in-country engagement with HISP to align on Tribe 360 linkage with DHIS2, and also part of the next plan is to ensure the Tribe 360 and Open LMIS are all up in the DHIS2, so that we can have a proper triangulation of both immunization supply chain data and program data to make an informed decision. Next. So this is a snapshot of the Nigerian platform for the Tribe 360, providing some level of visibility into the stock for the country in order to make an informed decision. Next. So we are also looking at tracking the zero-dose LGAs identified and the availability of stock data, so that we can properly be informed as to how they will be supported in terms of vaccine delivery. As I said, the Open LMIS has recently been deployed with 70% coverage for the LGAs, and that about 45% of the LGAs are of the 100 of the LGAs are already reporting on Tribe 360. So for the zero dose, about 51% of the zero dose LGAs are already reporting. We are having some form of visibility into their stock, and also 36% of the zero dose LGAs are currently reporting via the Tribe 360. Next.
So, Dr. Ahmad, thanks for raising your voice beyond the noise in your background. But if you can help reduce the noise in your background to help colleagues listening.
Okay. Thank you. Let me. Okay. All right. So in terms of cold chain expansion for equity and coverage, Nigeria has achieved tremendously. Recently, about 32 working cold rooms and 6 working freezer rooms have been deployed to the zones and states based on a gap analysis. We leverage on the funding sources of various partners that are available in country in making this giant stride. Next. So Nigeria has a policy of ensuring the attainment of a minimum of 1 active cold chain equipment per ward. And through the cold chain equipment optimization platform, the country have been pursuing this in the last couple of years. And as at now, the country was able to reach up to 96% level of saturation of cold chain equipments in all the wards of the country. The remaining 4% of the wards that are yet to have cold chain equipments are either completely security compromised, and the rest will be that are really accessible will be soon be deployed using other sources of funding, such as the ECO and also Government of Japan grant. Next. So by way of providing way forward, the country is considering instituting a monitoring mechanism for tracking progress in zero dose LGS and ensuring the implementation of key activities in those areas. We are also looking at fast-tracking the implementation of 3 hub projects to ensure sufficiency of storage capacity at national level, and also scale of last mile delivery in targeted LGAs using Drive initiative, and also improve stock reporting especially in zero-dose LGS and fast-track LMIS Tribe 360 interoperation with DHIS2. We are also looking at scaling up the innovative strategies of vaccine deliveries in hard-to-reach areas, security compromised areas using drones, and also long-range past cold chain equipment. We are also looking at sustaining the gains of the cold chain equipment ward saturation and ensure continuous maintenance and replacement of the cold chain equipment. Next. Thank you very much.
No, thank you very much, Dr. Ahmad and Fam Awa. I think as we did at the end of the RC presentation, we'll just take very few questions in 2-3 minutes. Thanks for keeping the question and answer function active. So I'll go to a few of them and then you can respond. So Karan is asking, how are you assessing the AQ&E both in 2020 and 2021? Have you done targeted EVM assessments? Please share your experience. And then someone has asked Dr. Ahmad to, Gail has asked that what are the main challenges to deploying open LMIS at point of service currently? And then the question of Tribe 360 LMIS, open HMIS interface, do we have to report separately into Tribe, or is there a way you're thinking of making sure that all interoperable? So 2-3 minutes to respond, and then we'll maybe have to move on. Thanks. Dr. Ahmad?
Thank you very much, Olamide. I hope I am able to capture all the questions as you are mentioning them. So for Karan asking about the targeted assessments, this year, Nigeria has not conducted any EVM assessment, whether targeted or nationwide, since the last EVM assessment. But however, it is part of the this year's work plan to conduct a minimum of 3 targeted EVM assessment, so as to validate our continuous improvement plan and also confirm the status of our EVM scores. On the challenges of deployment of the open LMIS includes actually in the beginning there have been a lag in the deployment of the open LMIS due to the conduct of the capacity building exercise for the deployment of the open LMIS because of the COVID-19 pandemic, and also the decision not to hold a physical training, but that was actually surmounted. And also the availability of the baseline data, which we had to conduct a nationwide physical stock count data, and then try to make sure it is the baseline data we are using for the open LMIS. Other challenges include the absence of a network in some areas, and also absence of a tab, which the country and partners had to make an effort to ensure tab and computers were supplied to the users of open LMIS. So these are some of the few challenges, and which were actually surmounted. Now we are looking at the quality of reporting, and also the capacity for continuous use of the open LMIS, and also the interoperability part of it to make best meaning of the data we are getting. Olamide, I hope I responded to, did I miss any question?
No, thank you very much. I think you responded to the questions I asked. I'll encourage yourselves and Dr. Dio and Dr. Patu to probably respond to some of the open questions through the Q&A function as we move on. Thank you very much. We'll still have a bit of time for questions at the end of the Pakistan presentation. But we'll move straight to how immunization supply chain contribute to coverage equity and zero dose in Pakistan. We have 3 excellent colleagues to share their experience, and Dr. Zafar is Director Technical, Federal Directorate of Immunization in Pakistan. Dr. Inam is the Deputy Director Operations from the Federal Directorate of Immunization, and Naeem Asgar is the Immunization Specialist for UNICEF Pakistan. So they're going to share their experience on a wide range of interventions they are also taking. They will have 20 minutes, And because we're about 5 minutes before 2 now, we would have about 15 minutes for question and answers, hopefully, so we can generate discussion. So over to you, Pakistan team.
Thank you, Dr. Almede, for your introduction. And so this is about the immunization supply chains, contribution to coverage, acuity, and zero dose in Pakistan. Next slide, please. Next, please. So this is basically cold chain equipment's key drivers. Then whatever the cold chain equipments are distributed, it is based on the gap analysis, the requirement of the provinces to increase EPI services points in public and private sectors. So basically, this aims to reach the zero dose children. Regarding this, all the cold chain equipments, standardization of the equipments in the country for the ease of maintenance and management. There are limited cold chain equipment selection of the manufacturers. So we have for us 2 manufacturers that they ensured about the warranty and the life of the services up to maintenance of the cold chain equipments. So B Medical, solar direct drives have the capacity of 10 years of the warranty, including ILRs and including the 5 years. So other country preferences regarding the management and maintenance of these cold chain equipments. Next, please. Okay, this is basically the distribution of the cold chain equipments all around the provinces, including the filtering areas of the Islamabad, including the AJK, Balochistan, Islamabad, GB, and these are the provinces, and then we have distributed the ILRs. So these cold chain equipment based on the equitable distribution, the concepts behind is that when we for example, take the Balochistan as scattered areas, and when we discuss about the geographical distribution of the Balochistan, it is basically the scattered areas, or it's accounted for the 4-6% of the populations. So when take example of the Punjab, so it is purely highly populated provinces in the Pakistan. So on basis of these 2 provinces comparison, so we distributed the cold chain equipments according to the equity based distribution. So when we look at the total distribution of the AJK, we have a distribution plan of 300, and same wise the Balochistan 553, and including Islamabad, GB, and these wise these basically the cold chain equipment distribution plan. Next, please. Okay, this is basically I want to give the concept clarification. The distribution is based on 3 types of deployment regarding the extension, expansion, and replacement. So when we look at this right side of the proportion, so we divided into these into the percentage of about the replacement. We counted for 14%, and the extension regarding these cold chain equipment is 43%, and regarding the expansion of this, it was count for the 43%. So next, please. Okay. So cold chain equipment prioritization to reaching to address the zero dose. The intervention is divided into, as already discussed in the previous slide. Purely the expansion and extension is when cumulative to this slide, it would be 86% would be addressing the zero dose reduction directly or indirectly. And then we have planned the construction of about 1,200 facilities in underserved population, and over 1,400 private facilities to be equipped through extension of the cold chain equipments. So this would be concluded as the 59% of the total cold chain equipment would be directly targeting on the reduction of the zero dose. This is basically the concept that I would like to share regarding these three interventions: expansion, extension, and reduction. Next, please. So I will request to Dr. Naeem to proceed further this slides of this Pakistan API supply chain design project overview.
Yeah, so thank you very much, Dr. Channa. So my name is Naeem Asghar. Good afternoon, colleagues. I'm from Islamabad. So I'm an immunization specialist for vaccine and cold chain management in UNICEF country of Islamabad. So just to summarize what Dr. Channa has said, that we are focusing that this equity lens in terms of distribution of cold chain equipment, which we have planned for next 3 years through this CCOP window, CCOP from Gavi full portfolio planning window. So that was overview which Dr. Channa has explained all of you. And now I would also try to share the experience of immunization system design study, so that we conducted a few years back in Pakistan, and now we are at phase of implementation of that recommendations of immunization system design in Pakistan. So Pakistan is, one of the biggest country, and high performing supply chain is needed to ensure life-saving vaccines. So like, for example, Pakistan procures more than 16 billion Pak rupees, or about $150 million vaccines annually. And so the changes or the recommendations that have been given in immunization system design, so can make our system more efficient, will be able to ensure availability of potent vaccines, will be able to ensure no stock out at all levels, and equity metrics were also considered when we were doing this system design study in Pakistan. So system design is one of the 5 focus areas to help Pakistan to reach EVM score from 74% in 2019 to more than 80% in 2024. And then it would also give a strong immunization, risk-free, cost-effective immunization supply chain system to reach hard to reach areas, and to enable to increase coverage and to reach zero-dose children, particularly in far-flung and scattered population like Balochistan and South KP. Next. Yeah. So this immunization supply chain modeling helped us to determine the impact of potential changes. So like, for example, we are in, as I explained, we are at the phase of implementation, and we want to make our immunization system risk-free through making multiple point of entries, both for dry logistics and vaccines. And then this intervention would also help to make this system cost-effective in terms of transportation, fixed operation, and then the value of inventory, which we have been managing in Pakistan since years. Then the effective utilization of storage, because we have scattered our storage capacity both in terms of dry logistics and cold storage, so that we would be able to use that capacity effectively if we'll go for multiple point of entry, both for dry and cold chain logistics. And then equity metrics were considered in account to ensure there is adequate cold chain capacity available for fully immunized children at all level. And then the distance between the different supply chain points from district to from provinces to district and from district to health facilities were also considered during the modeling of system design in Pakistan. Next. So these are were the major recommendations to positively impact the immunization supply chain system. Like, for example, change in point of entry, one of the key recommendation. And then we feel that there would be a great impact. It will go for the multiple point of entries in risk, in terms of risk mitigation, and then also it would be most cost effective. And so there would be definitely opportunity to reduce in-country distances handling, vaccines at different points, vaccines and dry logistics, and then also, reducing the risk of placing all logistics and vaccines at one place. Then it is also, supporting and helping us to optimize regional warehouses. So currently there is a big warehouse at National Store, and then all the logistics comes from seaport and from one airport in the capital to Islamabad, and then from Islamabad all the vaccines and dry logistics are again distributed to throughout the country. So now we are making different hubs throughout the country, so that when we would implement this change in point of entry, so that the dry logistics and the vaccines would directly go to those hubs, instead of all vaccines and dry logistics coming to Islamabad, which is in the northern part, seaport is in the southern part. So it travel all the way, come to Islamabad, and then from Islamabad it travel back to the rest of the provinces. So it is risky to put all dry logistic for a huge country of 220 million population at one place, and it is also not cost effective. Then it is also helping us to cross admin boundaries. So supply chain follows government and administrative structures, which may not always be the most effective and efficient way to deliver the vaccines. So potential cost saving, the recommendation is the potential cost saving, reduction in risk and equity improvement exist when delivery can cross the provincial boundaries. For instance, Sindh can make delivery to nearby division in Balochistan. So as I explained, the Sindh is the southern province of the country, and there is a seaport in Karachi where all dry logistic comes, and from Karachi these dry logistic travel all the way to Islamabad, and from Islamabad it travel to the rest of the provinces. And now we are making two big hubs, one in Karachi. So the Karachi share would be received in, Sindh share would be received in Karachi, which is the capital of Sindh province. And from Karachi, Balochistan is the nearest province. So dry logistic would be then shifted to another hub in Balochistan in district Lasbela, so that from that hub it would be distributed to the rest of province in Balochistan. So instead of coming back to Islamabad, so the distribution of the dry logistics and vaccines would be done from Karachi. So that would be the one point of entry. The other point of entry which we are planning for vaccine is Lahore. So that is the capital of biggest province of the country, Punjab, which is 53%. So instead of coming the vaccines in Islamabad, so vaccine would be received in Lahore and distributed for Punjab. So then Federal or Islamabad, which is the capital of the country, would only be, receive vaccines for rest of 20 vaccines and logistic for rest of 23% of the country instead of 100% of the country. So by doing this, our supply chain system would become more robust, cost effective, efficient, risk-free, and it would be, more efficient than the existing system. Next. Next. Yeah, so as I explained you that we are in process of implementation. So the change in point of entry and optimization of regional warehouses, these components are, almost at the stage of completion, that we have started construction of 3 warehouses where we are making the hub for dry logistic in Karachi, which is the capital of one of the province Sindh, Lahore, which is capital of the biggest province, which covers 53% of the country, that is Punjab, and then Lasbela, Balochistan. Balochistan is, by population, it's 6% of the country, but by area, it is 45% of the country. So it is with scattered population, and there are a lot of challenges in terms of, reaching the people up to the last mile. So this intervention would definitely help us to mitigate issue to ensure the adequate supply in Balochistan as well. So all dry logistic for Sindh, Punjab, and Balochistan will directly transported to these warehouses instead of coming to Islamabad and then again transported to these provinces. So we have set the timelines to change all these in point of entry for at least dry logistic by December 2023. And then next is the provincial and district stores. So for vaccines, we have recently deployed 91 walk-in cold rooms at 89 sites, and we scattered it geographically so that we would be making 2 point of entries 3 points of entries for vaccines in Karachi, which is the capital of Sindh province, and in Lahore, which is the capital of Punjab province, and then Islamabad. So vaccines would, Karachi would take care for Sindh and Balochistan, Lahore would take care for Islamabad, for Punjab, and Islamabad would take care for 3 federating regions and 1 big province, KP. So the timeline for change in point of entry for vaccines is by June 2024. So that is the second component. Next, the discussion point that was assigned to us is the stock management. Can you please go next? Yeah. So in Pakistan, so I'm glad to share that we have been using a web-based. So this is, you can see that the supply cycle for the stock management for Pakistan. So vaccines arrived at Islamabad airport, and then it's stored at national store, and then it go to the sub-national store. From sub-national store, it is distributed to district store. From district store, it is distributed to service delivery point. And then at service delivery point, vaccines are being administered through outreach or mobile or fixed site, mechanisms. So then waste management of the immunization waste, which is being generated through vaccine administration, and then this reporting mechanism. So that starts from health facility level and come up to the national level, and based on that reporting of data, we do forecasting and requirement for the next year. Next. So as I explained earlier, that we have been using this web-based vaccine logistic management information system to manage this vaccine stocks. So it also tells us about the inventory, all vaccines related transactions like vaccine record, issue, receipt, putting into the cold chain capacity, cold chain, and calculating the cold chain capacity to develop shipment plans. So this system is being used to do all these things. So then the system also tells us vaccine consumption, and also calculate open and close vial wastages at all levels. So then we have already introduced cold chain equipment inventory module in that system as well. Although we are using this WHO gap analysis tool to calculate this gap analysis, but after collecting all that inventory in that gap analysis tool, so we incorporate in this VLMIS and all closely monitor cold chain equipment and inventory in this web-based system. Next. Next. Yeah, so these are, you can see that different VLMIS reporting mechanisms. So it is helping us to nationwide standardized reporting mechanism in terms of immunization supply chain. It's sustainable because we have been doing this, using this system since 2014. So now this system has become mature. Hundreds of the peoples at provincial, district, and health facility cluster levels have been trained on that. This is fully owned by government of Pakistan, and then this has improved governance and accountability in terms of vaccine stock management, and then transparency as well. So due to the use of this system, so we have been maintaining zero stock out since the last 5-6 years. Up to the health facility level for all vaccines, and we have been fulfilling all our Gavi co-financing, because we are a Gavi country in terms of vaccine timely procurement of all vaccines in the country. So then you can see different graphs, different pie charts, so different kind of reporting mechanisms. So these reports are being generated through this system. Next. Yeah, so there is one challenge, because there are some other systems at health facility level or also working, like for example, for coverage and surveillance, we have this EPI MIS system, and for service delivery, we have this EVAC or Zindagi Mahfouz. These are actually immunization, registries. So these are, Android apps, so that are being used by vaccinators at health facility to report, vaccination coverage and other things. So now we have planned to do interoperability and integration of all these existing systems to make one, consolidated dashboard for country, so that the policymakers and the decision makers vaccinators would take a decision accordingly. And we are also trying to mitigate the challenge of multiple entries, which our workers at last mile are facing. So once all these systems would be integrated, so then these multiple entry systems and all the data would be coming on one dashboard, so that it would be easy for us to take a decision and to do forecasting and making shipment plans for vaccines and trial logistics. Over. Next. That was all about Pakistan. Thank you very much. So we are open for any questions. Thank you.
Thank you very much, Naheem, and Dr. Zafar for the presentation. We'll go quickly if we have some Pakistan-specific questions, and then we take questions for the three presentations. So if you could, so one for you, does the VLMIS include stocks at the last mile, the facility level clinics, vaccination centers? That's for you on the Pakistan presentation. And I think we have Oiza Macy with their hand up. We'll give them the opportunity to ask a question now. But could you please respond to George's question at this point? Thanks.
Yeah, sorry, what George is asking, I could not see his question in chat.
So does the VLMIS include stocks at the last mile?
Yeah. So currently the VLMIS system is working up to the district level. It's up to the lowest distribution level. So at service point level, so service point level report the manually on VLMIS generated forms. And then the people who are sitting at district level, they incorporate all that data which is coming from service delivery level. But as I have explained that now we are in process to introduce this immunization electronic registry web-based applications at service delivery level. So these vaccinators would be doing all that data. And these systems would be integrated with VLMIS. And then after that, this paper-based reporting from last mile would be, would be stopped, and all the data would be coming through that digital systems. Over. Thank you.
Thanks very much for your intervention. So perhaps we give the floor to Adanini for their intervention. I hope it's specific to Pakistan. Or is that Messi? And then Bonaventura. Could we enable them, Alex, if they are able to?
Sure. Give me a second.
Okay. Or is that Messi? Please go ahead, unmute yourself and speak, please.
Okay, he or she's still on mute, and I cannot help with that.
Exactly. So Bonaventura.
Yeah.
Bonaventura.
Sorry, I'm okay with the. Someone else can continue with the question. Thank you.
Okay, thank you. Oiza Messi, go ahead, unmute yourself now. Okay. If we don't have any, I think they may be having challenges on muting. If we don't have any questions, we could go to other questions that we've had. So for Nigeria, would you explain your cold chain inventory experience? What's the frequency of your inventory updates? That's one question for Nigeria. And then the second for Nigeria, what are the difference between Open LMIS and Thrive 360? So could you, Dr. Ahmad, could you go with those whilst we prepare other questions for yourselves and TRC? Dr. Ahmad?
Okay, thank you very much, Olamide. Starting from the last question, talking about the difference between the Open LMIS and Thrive 360. Basically, Thrive 360 is meant to converge, a country's data, into a single platform, and this includes the service delivery data, the coverage data, It helps in data-driven planning and decision making, at several levels, unlike the Open LMIS that provides the information about stock and some of the parameters around the stock management. The Tribe 360 look at both the service delivery data, including even some of the surveys to provide a very meaningful idea about the stock information, and also how program can benefit from the stock information. And it provides a kind of in-depth, immunization supply chain system analysis, visualization, and even profiling of various segments of the program. It brings the forecasting, the allocation, the shipment, consumption, the coverage, be it WENIC, mixed, and even the EVM assessments and other monitoring reports, and combine and triangulate with the stock data to provide a sense of direction for the program. So that's it. For the cold chain inventory, Nigeria conducted a nationwide cold chain inventory in 2018. Since then, there has not been a nationwide cold chain inventory, but a continuous monitoring and reporting on a quarterly basis, the cold chain inventory status. Currently, we are planning for another one using the WHO inventory gap analysis tool, and that hopefully by March we are going to have that particular one, and subsequently it will be updated once a cold chain equipment is added to the system, unlike a situation whereby you have to wait for a quarter to update the cold chain inventory. Over.
Thank you. Thank you very much, Dr. Ahmad. So probably, if you could mute, I'll go to Dr. Patu and Dr. Dio from DRC with a few questions. Is there any way to monitor the potency of the vaccines while on transit with drones? That's a question for you. And then another question from Felix, that was from Abiodun, and another question from Felix is that, what measures are factored in to ensure that there is reduction in vaccine wastage, since there's no push and pull approach, even though I see that you have talked about the reverse logistics with the drones, so you could also retrieve vaccines vials that are not being used. But I'll leave you to respond to those questions. Dr. Patu, Dr. Dio.
Thank you very much, Olamide. Regarding the first questions on what measures are taken for ensuring the potential of vaccines, in the drones we have the fridge tag, which helps to monitor the temperature of the vaccines from the point of departure to the landing point. And it is also equipped with the ice pack. So quality control is there. And just for your information, through our community survey, we found out that many people from the communities now prefer vaccines that are provided by drones because they know that they come quicker, faster, rather than those that come through traditional transportation. So this is it. For the second question about vaccine wastage, and I'm not sure about that one, but I know that we supply with health centers vaccine to health centers using the mains consumption rates of the health facility. And this is actually to reduce the waste due to maybe over provisions of vaccines when the consumption is lower. So we use the average consumption rates to estimate the demands. I think that's it from my side. I don't know if Dr. Dio has anything to add. Thank you.
Thank you. Thank you very much for those responses. I think they're great. One of the ways that could also reduce wastage, at least, if is to replenish appropriately and when needed. So 3 other questions for you in the DRC contingent. Is the use of drones applicable to all remote settings, and what's the level of capacity and technology? And related to that, for you and Nigeria, what steps do you think countries should take or can take to establish the use of drones to deliver vaccines to hard-to-reach areas? If you can answer those questions, and then we'll probably start wrapping up now, except we have a question for you. So we could go ahead with it.
Can I go ahead?
Yes, please.
Yeah, thank you. Regarding the first piece of the questions, whether the use of drones are applicable to all remote areas, I would say it depends. Here, we first do some preliminary or feasibility study to see whether or not the areas, those outreach areas, respond to some criteria in order to be served by drones. One of which is the regulatory criteria. Just to give an example, that there are some areas where drones are not allowed to fly here due to the national regulations. So in that way, even if the area is remote, that there is a barrier, a structural barrier that's prevent us from operating. So those are some of the things that we preliminarily do before defining the network. I'm sorry, Lami, that I didn't catch the second piece of the question. If you can come back quickly on that, I will respond.
Thank you. I think you've answered it implicitly in your first response. Perhaps you could take this one also. Was there a time where the drone delivery failed in delivering vaccine to either a service delivery point, outreach, or fixed location? And what is the reliability rate from your experience? Either yourself and Ahmad can also weigh in if he has additional.
Yeah, this is it's very, very rare to experience a failure of the system. As far as I know, it happened only one time, and it was at the taking off 3 minutes after takeoff. Then we experienced an issue with the drones, but those are smart drones. Whenever there is an issue, whenever there is, for example, a sudden change in the weather, they automatically go back. So waste due to system failure, very, very minimal. This I can assure. Thank you and over.
Thank you very much. Understanding that we have 2 more minutes, I'll lump a few questions on cost together. There's cost on average, total average cost for delivering one vaccine ampoule. I think those specifics, we can take those on bilaterally with the VillageReach team and with the Nigeria team. I think there's also who manages the drones when it reaches the community or health facilities. I think that will be still the drone operators, but we can definitely talk about specifics. How much is the drone price for one unit, and how would you advocate drone could you share specific specs of devices from Kun? We can talk about that later. Just as a way of wrapping up on the questions, Felix had asked, he appreciates the efforts of the countries. What level of robust engagement with private sector providers, especially in suburban, semi-urban, and remote areas? At least I can speak for the examples of Nigeria and DR Congo, where these implementations have taken place, that there's engagement of private sector in delivery. Drones are by default not a government asset, so private sector providers are involved in training and capacity building and engaged. Also in the last mile delivery effort that Nigeria talked about, that's been implemented and will be scaled. There's engagement of varied private sector providers to make last mile delivery, to deliver last mile, deliver commodities at the last mile in those 2 settings. So I hope that answers your question, Felix. I think as a way of wrapping up, thanks again, everyone, for attending this webinar. series on supply chain and zero dose on how supply chain contributes to identifying, targeting, and reaching zero dose communities. As I said when we started, there are 3 webinars in this series. One last week focused on guidance and strategies. The one today has really dived deep into interventions that contribute to reaching zero dose communities, especially focusing on lessons, best practices, and all that. And we hope you've truly enjoyed it. The last in the series will be next week, Thursday, the same time, 23rd February, the same time. I will focus on integrated supply chain approaches to reach underserved populations, ensuring that we can touch on primary health care, universal health coverage, what are the interventions that supply chain has with other sector of the health system, including water and sanitation, including environmental considerations, including integration. Those will be topics we will dive in next week, and I hope you will join us. So without further ado, thanks again for joining. Alex, do you have any closing words?
Yes, thank you very much. Excellent presentations and moderation. Thank you, guys. Just to remind everyone that we will send the presentation as well as the recordings by email. That's it, and we hope to see you again next week, same time, same day. Well, I think we can wrap up and close this webinar. Thanks a lot, everyone, and have a very nice rest of the day.
Thanks, everyone. Have a good rest of the day.
Bye-bye.
Okay.
Thank you.
Thank you very much,
Bye-bye.
everyone, for listening us. Thank you. Bye-bye.
Thank you. Bye-bye.
Au revoir. Merci.
Thank you.